Hello there and welcome to the channel. This is going to be something a bit different today. This is basically a transcript of a talk that I gave to fellow MSK physiotherapy colleagues a few months ago, all about the assessment and management of the most common hand and wrist conditions. So whilst this video is aimed at fellow professionals, if you are a patient with a hand or wrist problem, then do keep an eye out on the channel, because over the next few weeks I'm going to be making a video that goes along similar lines but is specifically aimed at patients rather than colleagues. So do check out that. But feel free to watch this. You might find something interesting or learn something about the way that we as professionals assess and manage the most common hand and wrist conditions. So I'm Stephen Bunting. I'm an MSK physiotherapist and sonographer based in the UK, and I have an interest in hand and wrist problems. So the way that I've structured this video is to break down the whole talk into two parts, part 1 and part 2. So this is part 1 that you're watching now, and this is going to start with just a basic introduction into how we assess hand and wrist conditions, and then we're going to look at the details of the most common hand and wrist pathologies involving the bones and the joints. And then part 2, which I'll link to up here and in the description below, is going to be where we discuss all the soft tissue conditions that affect the hand and the wrist. So let's get started with part 1. Okay, well, thanks for the introduction, and thanks for inviting me to come and talk to you about the assessment of the most common hand and wrist conditions that we see in clinical practice. So I'm Stephen Bunting. I'm an MSK physiotherapist and a sonographer based in the northwest of England. I've been in practice for about 28 years, the vast majority of that within MSK, and the majority of that specifically within hand and wrist conditions. So let's get started, and this first slide just shows you what the most common wrist and hand conditions are that we see in the UK. And the talk is going to discuss each one of these as we go along, particularly with regarding to assessment, diagnosis, and the treatment options as well. So these are the top 8. We've got carpal tunnel syndrome, we've got osteoarthritis in general, particularly of the fingers and the wrist. We've got Dupuytren's disease, we've got trigger digits, ganglion cysts, de Quervain's tenosynovitis, cubital tunnel syndrome, and wrist sprains. So those are the most common conditions that we see. But that's not what walks through the door. What walks through the door is a patient with a set of symptoms, and we have to marry up those symptoms with these particular conditions. And so the patient comes in complaining of pins and needles, of painful fingers and thumbs, of bent fingers, of lumps and bumps around the hand and wrist, and with general sore and painful wrists. So these are the symptoms that we have to unpick and marry up with our clinical assessment to try and come up with a diagnosis and then a plan of action following that. So before we talk about these individual conditions, let's just get some ground rules established first, and let's just establish what the hand and wrist language is, because if we're going to assess hand and wrists, then we need to talk the lingo, and we need to at least sound like we know what we're talking about. So first of all, with regard to orientation, we orientate the hand by talking about radial and ulnar rather than medial and lateral. If anything tells me that somebody doesn't know what they're talking about with a hand and wrist condition, then they'll be talking about medial and lateral, because of course that's going to change depending on hand position. What's lateral in one position will suddenly change when the arm is pronated or supinated. Of course, I'm aware of the anatomical position, but it does create confusion in the pro and supinated position. So to avoid confusion, and so everybody knows what we're talking about, we talk about radial over the thumb side of the wrist and ulnar over the little finger side of the wrist. And similarly, we don't talk about anterior or posterior in hand assessment. We talk about palmar and dorsal, or we talk about flexor and extensor surfaces. Both of those are acceptable, but not anterior and posterior, because again, anterior and posterior will change depending on the orientation of the hand. And lastly, we use proximal and distal, which is similar to other areas, but we don't use things like cephalad and caudad or superior and inferior. So we talk about distal and we talk about proximal. So using those basic terms, we can orientate ourselves anywhere around the wrist. And then also the naming of digits is important as well. I don't like to see people numbering their digits or fingers. So I don't like to see the index finger referred to as the first finger or the second digit. Again, it opens up an avenue of confusion, of course, because the thumb gets in the way when you're talking about fingers. And when you're talking about digits, people don't know if you're including the thumb or not, and then it just becomes confusing. So we don't have numbered digits. We have a thumb, an index finger, a middle finger, a ring finger, and a little finger, and that's it. And that's how we refer to them. So if you want to sound like you know what you're talking about when it comes to hand and wrist conditions, then that's the language, that's the nomenclature that we use. Okay, so let's get on with how we assess a hand for these conditions. So we're going to talk about history taking first, and the basics that I use when I'm looking at any hand that walks through the door for the first time. And some of the main things that we look at to start off with there are age. Okay, this is a really important factor when it comes to hand conditions. So of course you're going to take the age down of the patient, you're going to write it down, but what I mean is actually taking into consideration the age of the patient and what the most common conditions might be related to that age. For instance, if somebody comes in their mid-teens, then it's much less likely that they're going to have an osteoarthritic condition, and perhaps much more likely they might have a tenosynovitis condition. So it's just relating the age to the particular pathologies and seeing if that fits in with what we know is more common. Handedness is important. So does this patient, is it their dominant hand or arm which is affected here, or is it their non-dominant? And their occupation as well. So what are they spending their days doing with their hand? Really, really important when it comes to hand assessment. And not just occupation, hobbies, any repetitive or habitual activities that they're doing. What are they spending their time doing with their hands which may have generated this particular problem? And leading on to that, has there been a specific mechanism of injury that they are aware of and they can tell you about? Or is it more of an insidious problem and they've no idea? Or is it perhaps an overuse problem where they're doing something, again, habitually and repetitively? And when did it all start? Are we talking a few days ago? Are we talking 10 years ago? Are we talking something which is episodic or periodical? It's coming and going. How long did the episodes last for? And what are the symptoms that the patient's complaining of? We all presume that it's going to be pain, but particularly in the hand, it may well be paresthesia, tingling, numbness. It may be weakness. It may be some functional difficulties. It may be swellings. It may be a lump or a bump. Okay, so being precise about what the symptoms are or how the patient perceives their symptoms is really important. And then also the area of symptoms. Is this more of a global problem? Are they talking about general hand pain, general wrist pain, or are they pointing to a specific area, a specific part of the hand or the finger, which would perhaps then coincide with the area of anatomy that you may then be able to pin down to a particular problem? And then what are their functional problems? So what are they having difficulty with? Any particular activities? Again, relating to what they're doing with their hands every day. What are the particular things that they're having problems with? And again, just more generally, what aggravates the problem? What eases the problem? What are they avoiding doing like the plague? And what do they do when they're having a really bad day of it to try and give them some relief? All really important cues as to what problem we might be dealing with. And is there a diurnal pattern? Are they being kept awake at night by this problem? And if they are being kept awake at night, what do they do when they wake up with it? How do they get back to sleep again? Are they waking up repeatedly? What are they like first thing in the morning? Any different to the rest of the day? Etc. And then also really important is the patient journey. So what journey have they gone through in order to be sat in front of you in this clinic today? What professionals have they seen? What have they been told? Have they been given a diagnosis by anybody? How did that come about? Have they had any investigation? Have they had any treatments? So what has happened up until this point? And that could often be really important, and it can often determine how the patient perceives their problem, and you may have to break down some barriers and patient perceptions back down to ground level before building back up again in a logical manner what the problem might be, particularly if it's something that looks like it's very different to what they've been told by somebody else. And then when we actually examine the patient, okay, first thing I'll obviously do is just look at their hands, compare right to left, and the things that I'm looking at are the alignment of the fingers, particularly in the wrists. Are there any lumps and bumps or visible abnormalities? Are there any swellings? Is there any muscle wastage? And then what's the movement like? Just general movements of the wrist and forearm are really important. And then I just get them to roll their digits up, so curl their fingertips into their palm crease and then back out again. Get them to bring their thumb across their palm and back out again. And if they're free and pain-free and moving fully, then that's absolutely fine. If there's an individual digit that's not working as well as the others, then we can drill down and look at individual joints within the finger. But just general digital roll-up is a good, quick assessment tool of finger function. And so what I look at from this point on may be different from person to person depending on what their individual symptoms are. So it could involve looking at specific individual finger joints and their range of movement and checking the stability and ligamentous integrity. It could be looking at their sensation. It could be looking at their power, their grip strength, their pinch and power grip. It could be palpating around the wrist and the fingers, looking for particular problem areas. There may be some special tests related to certain pathologies. It may be that I'm looking at a Tinel's test if I'm suspecting carpal tunnel syndrome, or a Finkelstein's test if I'm considering a diagnosis of de Quervain's. So let's now run through some of these common risk conditions that I mentioned earlier, and we'll make a start with the wrist in general. So wrist pain, okay, this is a really common presenting factor, and there are a whole host of diagnoses that somebody with wrist pain could potentially have. It's a complex region. There are multiple different carpal joints and many possible diagnoses. So the things that are important in the history regarding the wrist are particularly the mechanism of any injury, whether there is a trauma involved, and what the nature of that trauma might be, or whether it's occurred insidiously, or whether there is a repetitive activity involved. Really, really important. One thing I also use as a tool with regard to wrist pain is to get the patient to point or identify where the area of discomfort or where the area of symptoms are, something called the one finger test. So if they use the hand and vaguely wrap around the wrist, then we may be talking about something a bit more non-specific. But if they're getting an individual finger and saying it's there or it's there, then that's really important information. So the one finger test when the patient is describing symptoms is something that I'll pay close attention to, and I'll often get them to do that. I'll get them to say, can you with one finger point to the precise area of your symptoms? So this is quite a nice slide as a bit of a cheat sheet almost, but if a patient's coming in with dorsal wrist pain, then I'll generally ask them if they can to localize whether it's over the ulnar side of the wrist, the radial side of the wrist, or the central region of the wrist. And obviously if they're pointing with their finger to a particular area, then that makes the job a bit easier for you as well. But if it's something over the ulnar dorsal side of the wrist, then the sort of diagnoses that you start thinking about, you start generating your hypotheses, might be the distal radio-ulnar joint has been a source of pain, the ulnocarpal joint or the TFCC, the extensor carpi ulnaris tendon, or the ligament over that side of the wrist, which may be relevant if it was a trauma history. If it's the central part of the wrist, then could it be the radiocarpal joints? Could it be the central extensor compartment tendons? Could it be a ganglion? Could it be Keinbock's disease, which we'll talk about later? Could it be, again, a ligament injury? And then over the radial side of the wrist, that's where the basal thumb joints live, which are a common problem. Could it be the de Quervain's tendons? Or if there was a trauma involved, this is the area where perhaps a scaphoid injury, a scaphoid fracture, might present with pain, or again it could be a ligamentous problem. And I've got a similar cheat sheet here for the palmar side of the wrist. So again, if it's over the radial side, then it could be those basal thumb joints. Again, it's a common area for ganglion cysts. It could be the flexor carpi radialis tendon, or again, it could be trauma like we discussed earlier, the scaphoid commonly, or a ligamentous injury. Central part of the wrist, we've got the flexor tendons. We've got carpal tunnel syndrome as being a common pathology around there. We've also got palmar ligaments as well. Over the ulnar side, we've got the distal radioulnar joint again. We've also got the pisotriquetral joint. We've got flexor carpi ulnaris tendon. We've got Guyon's canal, which can be an area where local pathology can occur. And we've got the ligaments as well. So that's the sort of thing that you might be thinking about based on those particular anatomical regions. Okay, so we're going to talk about acute wrist sprains. And this is likely to be a patient who's complaining vaguely of pains over either the flexor or the extensor surface of the wrist, depending on whether it was a forced extension or a forced flexion type of injury. Or it could be somebody who's had a very specific type of injury, and with one finger they're complaining of a certain corner of the wrist or a certain side of the wrist that coincides with the particular ligament that they've injured. But the key to a wrist sprain is there is always going to be a trauma history. And with these patients, then the first thing to do often is to reassure them, because we know that ligamentous sprains, even though they take a little bit longer in the wrist than they do other areas, and we're not quite sure why that is. We think it may be because the hand is so well innervated with nociceptors that it may just feel like it's taking a lot longer. And of course, because the hand is so active and not as easily rested compared to other areas as well. But nevertheless, we can reassure them and tell them that in the majority of cases, these wrist sprain injuries will often settle down over time reasonably well. And it may be that just analgesia or anti-inflammatories are the only thing that's really required to help them on that journey. Sometimes a wrist splint can be helpful as well, just to provide them with a little bit of rest. But then as soon as things start to improve, then we need to start changing that from not resting quite so much and then starting to introduce graded exercises at the right time when pain is starting to head in the right direction. If symptoms are unchanged or we're not making a huge amount of progress, then if they haven't had one already, then getting an x-ray done at around about that 12-week mark is often helpful, just to perhaps rule out maybe a scaphoid fracture that's been missed, or any other bony injury as well can often be quite helpful. So osteoarthritis is the other common condition that you can see around the wrist, and again, general wrist osteoarthritis will be that C-shaped description of symptoms a lot of the time, unless it's localized to an individual sort of finger or basal thumb joint, which again we'll get onto. But osteoarthritis as a condition we know can affect any synovial joint anywhere in the body, but in the hand and wrist it's most common in those basal thumb joints, in the DIP and the PIP joints of the fingers, which we call nodal osteoarthritis, in the wrist joint, the radiocarpal joints themselves, and in the distal radioulnar joint. So we know that this is a degenerative condition, but it can flare up as well from time to time and give almost inflammatory type symptoms as well, and generate effusions. But the general history with wrist osteoarthritis, of course, is that it's usually a slow, progressive onset. Generally a dull ache is the dominant symptom, and there may not be a trauma involved. It may be either insidious, or it may have just been irritated by repetitive activities. Classic symptoms are normally pain and stiffness, and you'll often pick up the stiffness on the examination of the suspected joint. So when I'm looking at osteoarthritic hands and trying to make a diagnosis, of course the history will be important, like we've mentioned before. And then on examination, I am looking at range of movement, and you'll often expect a loss of movement of that particular joint. There may well be pain on palpation of the joint margins and on stress testing of that particular joint. There may well be bony thickenings, basically osteophytes in the hand, and the wrist can be very visibly obvious. An X-ray is probably the most useful investigation, and that will often show one or all of the classic four indications of osteoarthritis, namely joint space narrowing, subchondral sclerosis, which is the whitened margins of the subchondral bone, subchondral cysts, and the formation of osteophytes. MRI and CT and ultrasound, we can count in that as well, aren't often needed to diagnose osteoarthritis, but can sometimes be helpful just to pick up additional features such as an effusion, or also to exclude other potential complications like AVN or an isolated osteochondral defect. And then getting on to management of osteoarthritis, and this sort of loose formulation will be similar to any osteoarthritic joint of the hand and fingers. But, you know, if it's a stiff joint, then there is some merit potentially in mobilizing these joints over a session or two. I know that manual therapy isn't a very popular thing to do at the moment in physiotherapy circles. But in my experience, I wouldn't waste more than a session or two, but sometimes it can be helpful to get the ball rolling before you then pushing on more of the self-management and the exercises. And of course, that becomes the mainstay of the rehabilitation treatment when it comes to osteoarthritis. And when it comes to exercises, I often try and focus on function and dexterity rather than, you know, sort of quite mundane anatomical exercises, should we say, you know, the ball squeezing type things. I think if you give them a functional task to do, then it generally is tolerated a lot better with patients, and they can see a reason to do it, and they're much more likely to do it. And of course, our role as therapists will often include lifestyle advice, ergonomic advice and education, just basically getting into the headspace of that individual patient and what they do on a day-to-day basis, and then using our knowledge that we've gleaned over years to advise them about how to get the best out of their hand and wrist, and suggesting any modifications that they might have to perhaps make. And also, reassurance is a really powerful tool as well. There are very negative connotations sometimes associated with osteoarthritis. You know, people often refer to it as wear and tear, which in patients' minds will suggest that the more they use it, then the quicker it's going to wear out. Which, of course, if you're then trying to prescribe exercises and getting them to use an individual joint, in their head they're thinking, well, hang on a minute, the more I use it, the more it's going to wear out. Should I be doing these exercises? That doesn't make sense. So it's trying to get them to understand that it's not a wear and tear condition. That's not the description that we should be using. But it is perhaps a degenerative condition, but it does respond to movement and exercise, and try and explain the stimulus response scenario that we're trying to invoke with these joints. And then we know that osteoarthritic joints can flare up from time to time, and that's when we get more significant pain and sometimes swellings and effusions. And those particular patients, then, they may well require a period of rest, and splints can be very helpful in order to try and achieve that. So splints are a commonly used and effective tool to settle down aggravated osteoarthritic joints. And at that point, you are sort of avoiding provocative exercises for that time until the joint has calmed back down. And the use of aids and adaptations can often be helpful, particularly in people that have got chronic, long-standing and quite advanced degenerative arthritis, particularly in the fingers. Then they may well find that some aids and adaptations, which again we'll get onto later, but they can be helpful. And then non-steroidals, I tend to use not so much tablets, but particularly the gels can be helpful around the hand and the wrist. You know, we're talking about quite superficial structures here, and so anti-inflammatory gels have got a good chance of penetrating to an effective therapeutic depth, and so I'll tend to use those with relative frequency, particularly if I'm dealing with a fairly small localized effusion. And then injections as well have got a strong role to play in the management of osteoarthritic joint flare-ups, and can be very effective at settling down symptoms very quickly. And then finally, surgery. So again, in pretty much most scenarios of hand and wrist osteoarthritis, once the conservative options have been explored and are no longer being effective, and if the patient's still got significantly intrusive symptoms, then surgery normally will have a role to play in some form or another at the end of that journey. So I'm going to run through some X-rays now, just highlighting some osteoarthritic joints and some associated conditions as well. So I've just put a normal hand X-ray up there, just for those of you who might be a little bit out of practice at hand and wrist anatomy. So I'll just leave you a moment just to have a look at that and just for that to sink in, because that's the normal that we're going to be perhaps comparing to. Now, normally when I do this talk, I'm doing it in a room full of people and I can show them an X-ray and they can shout out the answers. This is obviously not an interactive talk, unfortunately, although you will have a chance to ask questions at the end in written format. So what I'll do is when I put these X-rays up, I'll just leave you a few seconds just to ponder and come up with perhaps what you think might be the problem in your own mind, and then we'll go through the answers. So have a little look at that one first. I'll leave you a few seconds. And bearing in mind that, again, the pillars that we're looking at with osteoarthritis are joint space narrowing and sclerosis, that whitened area on the joint margins. And that sclerosis is often something that your eyes get drawn to in looking at hand X-rays. And hopefully you should be able to see there that it's the distal radio-ulnar joint there, which is the osteoarthritic joint. Just go back to the X-ray before and you can see that on that X-ray there we've got smooth margins, there's a gap, there's no sclerosis, and on the one that we're discussing then you can see the osteophytes, or it's almost like the head of the ulna has smoothed a little groove within the radius there, something that we call scalloping, and there's a whitened rim on the radial side of the joint as well that you can see, which is that sclerosis. So that's a typical osteoarthritic distal radio-ulnar joint. Okay, this is another reasonably common cause of ulnar-sided wrist pain. So this is ulnocarpal impaction or abutment. So this is basically a condition where you get impingement of the ulnar head on the carpus. There's multiple causes of this condition, but again, this is a patient who's going to be pointing to the ulnar border of the wrist as a main area of symptoms, and it's often associated with ulnar deviation and rotation movements. So grabbing hold of a screwdriver and aggressively trying to screw into a wall would be something that would really irritate this type of condition. And it can be associated with osteoarthritis changes within the ulnocarpal region or within the DRU joint. It can be associated with chondromalacia of the ulna, the triquetral or the lunate. It can occur as a result of a traumatic ligamentous tear to the lunotriquetral region. It can occur in TFCC injury or degeneration around that area. And it's more common in patients that have a positive ulnar variance, which is something that you'd pick up on X-ray. So as you can see here, on a normal X-ray, there should be a fairly straight line across the distal end of the radius flowing onto the distal end of the ulna there. And as you can see on the X-ray on the right, the ulna has almost shifted distally in comparison to the radius. And you can see now that the room now between the ulna and the triquetral and the capitate, and the lunate there is much more congested, and therefore you're much more likely to get an impaction or an abutment syndrome. So yeah, ulnar dorsal wrist pain is what we're going to complain of. So pain with gripping and pronation and ulnar deviation movement, that screwdriver movement I was mentioning before, very commonly irritable. Though you might get palpable tenderness just distal to the ulnar head, and the test there is that the person's demonstrating is called the Ulnocarpal Abutment test. So you support the patient's elbow with one hand, and then with the elbow bent to 90 degrees, you grab hold of the other hand, you take them into ulnar deviation, you sort of compress along the shaft of the ulna, and then you rotate into prone supination, and it's a pain provocative test. Treatment for this condition is again, you're getting the same idea now, aren't you, with these? You're resting from the aggravating activity. You might be splinting the wrist to try and provide some, to try and avoid them getting into ulnar deviation, essentially. So just a standard wrist splint. you're using non-steroidals if you need to do. Surgery can be an option with this. So depending on the individual condition, it could involve surgery around the TFCC, or it could involve something as radical as an ulnar shortening, an ulnar osteotomy procedure. And what I haven't put down there as well, but injection can be helpful for this as well. So injecting into the ulnocarpal space can sometimes provide some relief. It may be temporary, and it may be something that's used to help with diagnosis, but nevertheless has a role to play. Okay, we're now still on the ulnar corner of the wrist, but now we're sort of moving around onto the flexor side, the palmar side, and this is Pisotriquetral OA. So you can see there on the x-ray on the right, you can see the pisotriquetral joint, you can see that it's the joint space is narrow, you can see the sclerosis, and you can see that there are marginal osteophytes. And this is a condition which the patient will point directly to the pisiform as the main area of symptoms. And it's quite easy to provoke the symptoms. You basically grab hold of the pisiform between your finger and thumb. You flex the wrist slightly, which takes flexor carpi ulnaris off stretch, because that tendon attaches directly onto the pisiform. And you grab hold of it, you push it into the carpus, and you wiggle it from side to side. And it'll often be painful, and it'll also often feel like it's crunching and grinding, and that's a positive pisotriquetral grind test. Should mention as well, treatment for that, again, you can go through the same sort of scenarios as before. You can rest it, an anti-inflammatory, etc. That can be injected, often quite successfully, and then there's also the option of excision of excision of pisiform surgically as well. Okay, so on to the next one there. So again, I'll give you a moment, but hopefully your eyes are drawn towards the whitening and the joint margins, that sclerotic area, which you should be able to see there is associated with the thumb CMC joint, which is a very common joint to become osteoarthritic. So you can see that both on the trapezium side of the joint and on the metacarpal side of the joint, there is sclerosis, there's narrowing, and there's osteophytes as well. And it's just that one joint. The rest of the carpus looks in good health, doesn't it? And you look at the distal radioulnar joint compared to the one before. It looks very nice. So that's an isolated thumb CMC joint osteoarthritis. So this is a more marked example of the same condition. So you can see here that the base of the metacarpal has started to sublux radially, and then you've got that compensatory hyperextension of the MCP joint, creating that classical Z-shaped deformity, which can be seen in fairly marked examples of this condition. So I'm going to talk a little bit about thumb CMC joint osteoarthritis in a bit more detail, because this is a very common condition. So this is a condition with a strong female dominance of around about 4 to 5 to 1. We think that's because the ligaments in female hands are more lax generally than men. So we think that slight laxity or sloppiness of the thumb CMC joint can then over years and years lead to the degeneration that we see. Symptoms are commonly very local pain over the basal thumb region, and it can be over the dorsal side or over the palmar side, and sometimes they'll use a finger and thumb to sort of almost pinch around that area when they're describing symptoms. It's the typical osteoarthritis pattern. It's a dull ache, but it's worse with movements, and the movements particularly in this condition are pinch gripping and rotating. So classically, putting a key in a stiff lock and rotating will be something that will be avoided like the plague in somebody with this condition. And ultimately, because of the weakness they can then get, they generally complain sometimes of clumsiness and just general grip weakness. So on examination, it's useful to look at that pinch grip, and it will often be pain provocative. So check that out. Direct palpation is obviously really important, and we've got something called the grind test, where we can grab hold of the base of the metacarpal with one hand, support the trapezium with the other hand, and then sort of almost push and rotate the two bones against each other, and that's a pain provocative test, which is reasonably sensitive and specific for thumb base OA. And during the sort of more advanced stages of the condition, you can sometimes get that thumb-based squaring, which you can see in the picture there. X-ray is again a very useful investigation, as we've just seen. But having said that, X-rays, or rather the severity of arthritis on X-rays, doesn't always marry up with the severity of symptoms. I've seen people in my career with very, very advanced thumb CMC OA with hardly any symptoms at all. And again, I've seen the opposite scenario as well. So let's now talk about osteoarthritis thumb CMC joint management. And the management will consist of the similar type of things that we use for osteoarthritic joints elsewhere in the hand of the wrist. So we're starting off with anti-inflammatory gels and analgesias, and then we're generally talking about rest with splints in most cases, because by the time they're coming to see you, they've normally got a very painful or annoyed joint. You can give exercises, and you have to be careful with them, because generally most osteoarthritic joints you are trying to encourage movement and exercise, but this particular joint, it's very easy to flare it up. You know, pinch gripping is the thing that they're telling you is really painful, so you don't want to be giving them pinch gripping activities to kind of do if it's going to be pain provocative. So if anything, I'll give very basic things, you know, finger to thumb tapping perhaps, that maintains movement but doesn't aggravate symptoms, or perhaps static pinch gripping if anything, but not sort of the rotation stuff. But in most cases, you're more likely to be resting it rather than exercising it. Like I said, topical gels can be helpful. Capsaicin cream is also licensed for osteoarthritic joints at the 0.025% strength. So if you can get hold of that, I know there's been an availability issue over the last year or so, but that can potentially be helpful. But when you're coming to resting it, splints are the thing which are going to be most helpful. And these can be used, when I give these out, I tell the patients to use it pretty much all the time for about 6 weeks and see if they can calm the thumb joint down. And then once it's calmed down, they can start to wean off it. If it's painful at night, they can use it at night, but during the days when it's perhaps is going to be most useful. This is the type of splint that we provide at the practice where I work, and this is sort of the first line one that we use. As with any splint, they are a trade-off between allowing movement of the joint while providing an adequate amount of support. This one, again, provides a reasonable amount of support and allows a fairly good amount of movement. So it's the one that we use to start off with. But if it's not enough support, then we move on to something like this. This is a Rhizo Ligaflex splint. And this provides much more support, but at the expense of movement. So again, it's a trade-off, isn't it? But that can be something which is helpful for the right type of patient. This next one is the one that I tend to recommend in private practice, but it's quite expensive, so it's generally not funded by the NHS. And it's the Push Metasplint. It's about £50, but in my experience, if you've got a chronic condition and you find that splints are very helpful, then this is going to last a lot longer than the other ones and is going to provide generally more adequate support while still allowing a reasonable amount of hand function. Other things to consider are injections, so I do quite a lot of these, and you can do them landmark, or you can do them guided. I did them for 10 years landmark before learning how to do them guided when I trained to be a sonographer, and I will always do them guided now because it just makes it so much easier in terms of accuracy. But if you're happy and you're competent, then doing them landmark is absolutely fine. They will be a little bit more fiddly, and you need to be well practiced at doing these and do them regularly, I think, to get competent, but doing them landmark is perfectly fine. And then surgery is the final option for this condition. So this X-ray shows a fusion, and you might think that that's a bit drastic, but actually it can be a very helpful and useful operation, particularly for younger patients, actually, because it maintains the strength of the joint, whereas some of the others have a bit of a propensity to induce a little bit of laxity or a bit of weakness whilst getting rid of the pain. So that can be a helpful operation. Of course, when you think about it, the thumb CMC joint doesn't move a massive amount, And if you've still got the wrist, the STT joint, the thumb, MCP and IP joints, then you've generally still got plenty of movement still available in that thumb, despite the fact that your CMC joint is fused. So it can be a good operation for the right person. The most common operation, however, is the trapeziectomy, which is shown on the picture there. If it's just thumb CMC joint osteoarthritis and the STT joint is in good condition, then you can get away with a partial trapeziectomy where they just remove the distal portion of the trapezium. But if both those joints are involved, then they have to remove the entire trapezium. And then more recently, and it has really been over the last few years, specialist centres are now providing thumb CMC joint replacements. But again, these are normally done by specialist orthopaedic hospitals. But from what I've seen so far, the results seem to be very good. But we're kind of just watching this space really, and hopefully this is a procedure that will get rolled out to more routine orthopaedic departments in the future. So let's have a look at this next x-ray here, and I've kind of given the game away really when I've been talking about STT joint osteoarthritis over the last few minutes, because this is, as you can see, your eyes are drawn, aren't they, to the articulation between the scaphoid there and the trapezium. It's that whitening, isn't it, and that very narrow joint that you can see, particularly on the right one there. So that's STT joint osteoarthritis. The CMC looks okay, doesn't it? But it will give very similar symptoms to CMC joint OA. If you're very good with your grind test and your palpation, then you may be able to discriminate between the two. But otherwise, symptoms are going to be fairly similar, and you're going to need an X-ray in order to tell which is which. So STT joint OA, again, you can see this on it. This X-ray here, it's very sclerotic, isn't it? And your eyes are drawn immediately to that area. So the management is exactly the same as the STT joint, with the one exception that I probably wouldn't advise a landmark injection for this, mainly because there is a branch of the radial artery that sits directly over that area. And whilst if you did pierce it with a needle, it's not the end of the world. You know, it's not going to be particularly nice for the patient, and is easily avoided if you do it under ultrasound guidance. Okay, so moving down into the fingers. So nodal osteoarthritis, a very, very common condition. So as you can see on the x-ray quite nicely there, this patient has got a mix of DIP and PIP joint osteoarthritis. Again, if you look, you're drawn towards the sclerosis, the joint space narrowing, the osteophytes, you've got subchondral cysts there. And individual to this joint, you've also got the angulation, the distal angulation that you can see particularly in the middle finger DIP joint there. And you can also as well see the soft tissue, it's not really swelling, but it's more soft tissue bulging around the Heberdin's nodes and around the Bouchard's nodes that you can see there. So these Heberdin's and Bouchard's nodes are basically just osteophytes, but we refer to them as those particular nodes when they're localized to the DIP and PIP joints respectively. This slide is just a summary of nodal osteoarthritis management, and again, a lot of it is very similar to the general osteoarthritic management that we've discussed already, but some individual things here that may be a bit different that I picked out. So the top left picture there, that's Coban, that's an elasticated wrap that can be very helpful for IP joints. So they can cut a strip off and they can wrap it around the finger, it sticks to itself, and while it's on, it can provide some support, some compressive support, which can be helpful, but it also just cushions them against those annoying little knocks and bangs that you inevitably get when you've got an osteoarthritic finger joint. And it's good stuff, this. You can peel it off at the end of the day, you can put it on again the next day, so a roll like that, you can see in the picture, will often last many, many months. It's a really useful product. And then moving along there, you can see that patient's got their hand in a wax bath. Those people that might be my age might remember wax baths from old. So these used to be big metal vats of molten paraffin wax that used to adorn most physiotherapy departments and occupational therapy departments. And patients used to find this very, very effective in terms of just short-term pain relief. But of course, they'd be coming in every week for this. And, when money started to become a bit tight and infection control started poking their oar in, these treatments very quickly became phased out and you don't see them anymore. But you can buy wax baths, small ones like that, readily available online that I've seen for around about the £60-70 mark. So they can be very helpful for people that have got multiple fingers particularly affected. And if they use this every night, it can provide some nice therapeutic relief essentially. Top right are just demonstrating some of the functional exercises that I mentioned before. So with finger OA, rather than the typical ball squeezing things, they're more likely to do them if you do something that's a little bit more functional and enjoyable. So we've got a Rubik's Cube there. Then we've got somebody tying knots in a shoelace and untying them again. That can be useful. Playing cards, shuffling cards, turning them over. We've got them manipulating blue tack, or you can get therapeutic putty into different shapes as well. Can be very helpful. And then at the bottom there, we've got some of the various aids and adaptations that you can use for some of the everyday household tasks, including things that go over keys, cutlery, pens, and then the bits for opening tins and jars there. And then in the middle there, we've got cortisone injection into the PIP joint. Okay, so have a little look at this next X-ray. So hopefully you can see there that the osteoarthritis here is localized to the articulation between the scaphoid and the radius. So this is wrist joint osteoarthritis. So again, it's the same formula, isn't it? Analgesia, therapeutic heat can be helpful. Those wax baths can be helpful. Gentle exercise that's not pain provocative. Wrist splints at the right time. Injections can be very helpful, and ultimately surgery. So surgery can consist of fusion. That can be very helpful in certain wrists, and in this particular case here, wrist joint replacement. So surgeons have got a couple of different options, but also this particular type of osteoarthritis where it's localized to just the radioscaphoid joint, but yet the articulation between the lunate and the radius is actually in good condition. Then they've got a third option, which is called a excision of scaphoid. So you can see their scaphoid has been removed, and then what's called a four-corner fusion, where the ulnar side of the carpus has become fused to one. So that fused segment of carpus now articulates with the end of the radius and forms a new joint. So that sometimes gets called a partial wrist fusion. Well, that's an excision of scaphoid and four-corner fusion. Okay, have a look at this next one. So this isn't so much osteoarthritis, but hopefully your eyes will be drawn to the lunate bone there, which is completely sclerotic, isn't it? And this essentially is Keinbock's disease. So this is a condition where the lunate undergoes avascular necrosis. We don't particularly know why it happens in some people, but it seems to be a vascular issue. It most commonly occurs in males between the age of 40 and 60. It can occur due to trauma, but in most cases it is just congenital and occurs insidiously. There has been some links associated with autoimmune disorders, particularly lupus. And the symptoms of this are going to be a vague central wrist pain. And it might be the sort of thing that you might initially think is a wrist sprain and treated as such, but then at that 12-week mark earlier when I was saying to get them x-rayed, this is perhaps when something like this might come about. So treatment for this is either conservative or surgical. Conservative generally follows the same sort of rules as wrist osteoarthritis like we discussed before, but ultimately in most cases surgery is usually required, because if it's left too late, then as you can see with this one here, the lunate is sort of virtually disintegrated and capitate is sort of pushing down into the space that it's vacating, and that can create sort of further complications. Which brings us on to the next condition that I want to discuss. Have a little look at this x-ray and just see what you think. Anything standing out? It's not osteoarthritis, but hopefully you can see there that there is quite a large gap between scaphoid on the right and lunate in the middle there. And this is something called scapholunate dissociation. So this is a ligamentous injury. This is usually caused by a trauma, and what happens is the scapholunate ligament becomes ruptured. That's the ligament that binds those two bones together, and when it's ruptured they can separate, and you get this classic x-ray image, which is sometimes referred to as a positive Terry Thomas sign. And those of you that are familiar with Terry Thomas will probably know why. There he is, and with his big gap in his teeth at the front there. So you can see where that particular x-ray gets its name from. This condition can sometimes lead to symptoms of instability, so painful clunking of the wrist during movement. And one of the tests that can be used is something called Watson's test. So what you do here is with one hand you pinch the distal pole of the scaphoid, and with the other hand you passively take the patient's wrist from ulnar deviation through into radial deviation, and a positive sign is where you get a clunk and pain reproduction. Chronic scapholunate instability through that type of injury can eventually result in a condition called scapholunate advanced collapse, which often gets referred to as being a slack wrist. And these x-rays here show this fairly perfectly. So as you can see, what's happened here is the gap between scaphoid and lunate has become wider and wider over the years. Capitate is pushing into that gap and is essentially pushing scaphoid into the distal radius, causing quite advanced osteoarthritis of the radioscaphoid joint. So that is going to need surgical attention. And one of the more common things that they do for that scenario is something called a proximal row carpectomy. So they remove the entire proximal row of carpal bones, and the patient's wrist then consists of an articulation between the remaining capitate and the radius, so that they've still got some movement available. Okay, have a look at that x-ray and see what you think. Again, this is not osteoarthritis. The little exclamation mark should give you a clue there that there is something that the radiographer has been concerned about and has brought it to the attention of the radiologist. And it's a scaphoid fracture, so you can see right across the waist of the scaphoid you can just about make out the fracture line. It is subtle, granted, but that's often how they appear, and they can be sometimes easily missed, which is why they do often multiple views when they're suspecting a scaphoid fracture. There we have a slightly more obvious one that you can see on the left side there. So that is obviously, that's fractured, and the two ends of the proximal and distal poles have migrated away from each other. It's quite nice, that one, because you can see it compared to the intact scaphoid on the right hand. And that's the result of an untreated scaphoid fracture, which has just gone missed and has progressed into quite advanced osteoarthritis. And at this stage, really, there's probably the only option that the surgeon might have at this point is total wrist fusion. So that's pretty much highlights the importance of why scaphoid fractures, it's so important to identify them as early as possible so that they can be treated and avoid this type of scenario developing further down the line. Okay, nearly there now. And the last thing I want to talk about is MCP joint pain. So this is a joint, or these joints are affected by osteoarthritis much less commonly than some of the other joints in the hand, particularly the PIP joints and the basal thumb joints. But as you can see in the x-ray there, that's a fairly classic picture of an osteoarthritic index finger MCP joint. And we've got all those classic signs that we were looking at before. We've got the joint space narrowing, we've got the subchondral sclerosis and subchondral cysts there in the metacarpal head, and we've got osteophytes as well. So these joints aren't immune to osteoarthritis, just bear that in mind. But of course, if you do have somebody with MCP joint pain and swelling, particularly if it's multiple joints and particularly if it's bilateral, then do suspect an inflammatory condition such as rheumatoid arthritis, which has a propensity for the MCP joints. And so just have that in mind. So a couple of things that we can do if we're suspecting rheumatoid arthritis. Of course, we've got the blood tests, but the other thing that we can do in clinical examination is the metacarpal squeeze test, which is where you basically squeeze across the metacarpals, squeeze them together, and that's a pain provocative test. So if that's positive, particularly bilateral, then your index of suspicion is raised. The other thing that you might see, probably not so much now because we pick rheumatoid up much quicker these days, but nevertheless, if you've had a patient that's had it for a long time and it's gone undiagnosed, then you can get the classic ulnar drift of the MCP joints that you can see depicted in the picture there. And then another condition that I want to mention as well is a condition that we see associated with the thumb MCP joint, and that's Gamekeepers Thumb, which is a bit of an old-fashioned name, so also gets termed skier's thumb, because it's an injury where you get a rupture of the ulnar collateral ligament of the thumb. So as the picture at the top right there just depicts the type of injury that occurs. So the thumb gets jammed down into something, and then the joint opens up on the ulnar side and tears the ulnar collateral ligament. So clinically, you're going to see joint laxity. So as you can see in the bottom right there, that's the clinical test for it. You basically grab hold of the metacarpal, and then what you'll find is that you've got quite a lot of laxity when you produce a radial movement of the phalanx there. And that's one that's really important to compare to the opposite side and just get an idea of how much movement that there is. But that is something that we see with relative frequency, is that condition. And then the final thing I just want to show you, take a look at that picture there. So we're looking there at the index and middle fingers, looking quite proud compared to the other ones. So this sometimes gets called the iron fist or the iron salute. There's an x-ray there showing the sort of whitening around the joint margins of the MCP joints, index and middle there. And this is Haemochromatosis. So this is obviously a condition which has many different symptoms and affects many different areas, but amongst those it can affect the joints, and particularly the index and middle finger MCP joints of the hand. So it's a congenital iron overload, and like it says there's multiple symptoms including liver disease, heart failure, skin bronzing, endocrine disorders and diabetes, but joint pain and stiffness, classically these two joints are something that might bring to your attention that you might be dealing with haemochromatosis. And a simple blood test is normally all that's required in order to confirm the presence of this condition. Okay, so well done for making it to the end. That wraps up part 1. Part 2 I'll put a link to up here and in the description below, and that's going to look at all the soft tissue problems that we see around the hand and wrist.